So we have a few areas to cover. We will start with coronaries and cardiac imaging. Is that okay?
Yeah. So can I?
Yeah, please.
Just a little story here. The first question that he had asked about CT and ionizing radiation and MR and ionizing radiation. So way back in 2003, we were putting an MRI in our Bhaveshwar VR building, which is a ground plus first commercial and the rest is residential. And one of the tenants filed a case against us saying that all this is very harmful, and he wrote down that MRI causes radiation and people will die of cancer in the future. And we told half the tenants were with us, half were with him for a variety of reasons, as always happens. Went to court, and we had a very smart lawyer who kept. So status quo was we could go ahead and install the machine because the stay order was maintain status quo, which was we had started installing. So that was not an issue, but clearly if we lost the case, we would have had to install it somewhere else. And my lawyer was very smart, so he kept delaying the case until he found the right judge. The judge in the end was Dr. R.M. Lodha. Right judge in the sense, someone smart and intelligent who understood this. So Lodha Sahab looks at the final hearing, looks at it and says, "Ye kya hai? MRI mein radiation thodi hota hai. Ye to mere ko bhi malum hai." And he told the guy, "Case is dismissed. This is all wrong." And he's asking us, do you want to file charges against that? It just took that much, right? I mean, otherwise they would have to do research, etc. But when a judge says, "Mere ko bhi itna malum hai, ye kya stupidity hai," that was the end of it. So I'm just saying, sometimes these things matter, in life.
Okay, so first we'll start with coronaries, and we have two investigations for the coronaries. One is coronary CT angiography, and one is a coronary artery calcium score. First, let us talk about the calcium score, which is a less invasive investigation. What is, on a scale of 1 to 10, what is your confidence level in coronary artery calcium scoring for predicting events?
So in predicting events, my confidence level would be as high as 8 to 9.
Okay.
Calcium score now has, the data that we have is longitudinally over almost 30 years. And it's quite clear that in intermediate risk people, so and you have to be asymptomatic. So asymptomatic intermediate risk, which means, let's say, family history, LDL above 120, 130, sedentary lifestyle, smoker, in the age range of about 45 to 60. If you do a calcium score and the calcium score is 0, that means there are no calcified plaques in the coronary arteries, your chance of developing an event in the next 5 years is almost 0. Obviously, it's not 0. You could still have 1 in 10,000 getting an event, but it's almost 0. If after 5, so we call it the power of 0. If after 5 years, the calcium score remains 0, so now you call it the power of 00, then the chance of you developing an event in the next 20 years is pretty much 0. It's very, very low. If the calcium score is above 400, it means you have coronary artery disease, and the chance of you getting an event in the next 5 years climbs up that much. It doesn't mean you have a block. It doesn't mean that you will have an event tomorrow. It just means that you are at a higher risk of an event as compared to somebody whose calcium score is 0 or lower. And that would mean that you have to intensify your efforts to reduce risk, which then comes down to 4 pillars, which I'm sure you all have discussed earlier, but sensible eating, physical activity, statins and aspirin. These are our 4 pillars that we have, and that would have to be intensified to reduce risk. That's
So,
about.
the debate that we have as family physicians is who to ask calcium score test. How many of you have done a calcium score? Okay, a few of you have done a calcium score. So, Nimish bhai, you did a calcium score because you're his friend or because? Okay, so basically the reason for doing a calcium score possibly, as he said, is one, you have to be asymptomatic. You don't have a treadmill positive test or an angina because that would demand a greater investigation. And you should be having a few risk profile areas, age, diabetes, blood pressure, smoking, basically obesity, etc. And then you might do a calcium score. How will a calcium score help us family physicians or generalists? How will it help? If it is 0, what we can say is you don't need a statin, etc. If a diabetic patient has a 0 calcium score, do we remove the statin from the diabetic patient? No, we don't remove the statin from the diabetic patient. But we can make a call. So we have these 4 or 5 criteria for giving statins. For example, one of our criteria is 190 LDL absolute value in an asymptomatic patient. Now, if that asymptomatic patient has a calcium score added to a 160 LDL, you might want to give a statin to such a patient. So we are still in a gray zone as per recommendations of statin and aspirin related to what score are we talking about. But I think what he said is 0, normal, 400 plus, definitely abnormal. But between 100, 400 or 0, 100, we are in a gray zone. Is that right?
Absolutely. And you have to use all the other details, your LDL level, total glyceride, triglyceride, perhaps even your LPA,
lipoprotein,
all of that put together, including the lifestyle, family history, all of that, and then decide what works for somebody. But one word of caution, and I've seen this sometimes with doctors, sometimes with very hyper patients. Let's say you have a calcium score of 600 or 700. That's a risk predictor. If you're asymptomatic, you're asymptomatic. It doesn't mean that you have to panic. It is only it's just a call that tells you, maybe you need to reassess your life. But sometimes the panic buttons are pressed so hard that they start deciding to get an angiogram done, a catheter angiogram done. If you do a catheter angiogram in a calcium score of 600 to 800, you are likely to find some areas of narrowing or stenosis. But if you are asymptomatic, and as long as you don't have juicy, non-calcified plaques that could rupture and produce sudden cardiac death, as Dr. Manu Kothari used to say, of course, he used to go overboard on the whole thing, but our bodies also adapt. So if you have a 60% stenosis because of calcified plaques, or even if it's 70%, if it's been there for a long time and your collaterals have formed and you're asymptomatic, right? At the most, let's say at 600, you could do a treadmill test and just make sure that you're otherwise fine. But even that is really not required. So if you don't have any other problems, you don't really want to do an unnecessary test to add probably then an unnecessary procedure. I mean, end of the day, you can't fault the cardiologist for saying, I can see a 70%, should I put a stent inside? That's their job. I mean, they will mention it. Then you have another procedure and then another procedure, and it just goes on and on. So that's why sometimes these tests create their own problems, because they lead you down a path which was perhaps not required. So that, I think, is important. It needs to be taken in the correct context. It's a risk predictor. It doesn't tell you that you have to tomorrow do a cath angio and, take this further down.
If I have a patient who's high risk profile, I send the patient for a coronary CT calcium score. Can I tell you on my prescription that if the calcium score is more than 400, in this particular patient because of high risk, please go ahead with a coronary CT angio. Can I tell you that?
Yeah,
Or
that's
is-
fine. That's,
is- I can
that
tell
does happen, yes.
That does happen,
Yeah,
okay.
yeah.
What is the radiation? We just spoke about how the radiation risk of coronary angiography through CT scan and through catheterization is not very different. What is the comparison between radiation risk of both? Can I then advise, instead of doing two procedures, sometimes if I get an abnormal coronary angio, I will have to do a catheter angio and double the radiation of the patient, double the dye used. Should I?
Yeah, so now, you've stirred a sleeping rabid dog. So when the answer was given that, the radiation, X-ray causes radiation and harm, and children, for example, are at more harm, that's traditional teaching. So the answers obviously were right, but it's not correct. Okay, so let's just look at the entire issue of radiation risk. Theoretically, radiation of any amount is supposed to produce DNA mutations that then have the possibility of producing cancer, right? That part we understand. Till 1987 or 88, nobody talked about radiation risk to any great extent except to professionals. So as radiologists, when we did fluoroscopy, we had to take care of our own cells with lead aprons, thyroid shields, lead glasses, and all of that. Nobody talked of patient-related radiation risk unless it was a nuclear accident or an atomic bomb or attack or something like that. Then came a paper which did something called an extrapolation of data from Hiroshima and Nagasaki, where they said that if 1,000 millisieverts of exposure produces X risk of cancer, then 1 millisievert of exposure can produce 1,000 divided by X divided by 1,000 risk of cancer. It was a mathematical computation that if that is the case, then that means no amount of radiation is safe and every amount of radiation has its risk. So 1 millisievert is what in those days a chest X-ray would produce. Today in our CT scans we have radiation doses of 2 to 3 millisieverts for a plain CT scan. Now, this is a theory. It's a hypothesis based on mathematics, but it went viral in those days without any social media. The newspapers picked it up. In Australia, CT scans went down by 65% for that year. A lot of things happened. And physicists, because you're in the academic world, you have to publish, this became a whole spate. Then they started saying, oh, but this patient received 25 millisieverts, so that person's risk is now 10 times more than a chest X-ray. And you must have read all this, in the Times of India in those days, and it would all be everywhere. In the last 30 years, an entire generation of doctors and radiologists has come to now believe that therefore radiation produces cancer and we should be careful, etc., etc. It's been 129 years since the discovery of X-rays, 128 years. We're not talking of 10 years, 20 years. Statins is 35 years and we're still talking of statin-related myopathy because there is data. 128 years after the use of the first X-ray machine, there is not one single randomized controlled trial or a prospective study that shows that radiation produces cancer in adults. And I'll come to children in a little while. In adults, not one. You would think in 128 years, just following people, you would have one study that shows that radiation from diagnostic imaging would produce cancer. Even radiologists don't have an increased risk of cancer, and we are exposed to radiation with fluoroscopy, etc., etc. Now, the reason for that is because there's a safe limit of 50 millisieverts within which you don't. So we call it the low-no threshold theory, where there is a threshold below which you don't have an increased risk, and the body takes care of the insults that occur. But that is the theory again. But you would just ask yourself that if there is no data, then how can, as medical people, as people of science, we eventually look at data, right? You look at prospective studies, you look at retrospective studies, observational data, RCTs, but some study, nothing in adults. Now, when you come to children, there are 2 studies that have shown that children exposed to radiation have a 1 in 10,000 chance of getting leukemia or a solid tumor somewhere in the body. But there the WHO has come around and said that we don't know whether this was reverse causation. That means, was the CT scan done because the patient was symptomatic, but the tumor had not yet manifested in the body, and in later, a year or 2 later, the tumor showed up. So the tumor was already there, not caused by the CT, etc. Because you have to eliminate reverse causation. I mean, somebody doesn't get a CT scan done for time pass, no? There is a symptom, you have a headache, you have something. This is all about CT brain. Something is there, therefore you've gone to get a CT done. And then you develop a tumor. What if the tumor was already there and you didn't know about it? But even if you leave that out, even if, as we say, okay, children are a little more sensitive to radiation and perhaps them we have to be careful, it's 1 in 10,000 people who receive radiation that you have an increased incidence of cancer. It's ridiculously low. So in adults, it doesn't matter. One more thing, and this I sometimes have to tell helicopter daughters especially, and children. You know what helicopter children are, right? Constantly hovering around their children or their parents, right? So let's say you have a 70-year-old who requires a CT scan. So the child, the son, daughter, son-in-law, somebody will come and say, "Are pan emne radiation thase, pachi su thase." So even if you assume for a moment that radiation produces cancer, the effect of that mutation is 20 years. So if you already have a CA lung and you need to get a PET CT done every 3 months, you're not going to live 20 years, no, to get another cancer. I mean, come on, yeah. So you need to explain all this. It was so bad, there was a CEO of a bank, a lady who had CA breast, metastatic, who only used to get whole body MRIs done because she believed that radiation produces risk. Now, metastatic CA breast, the best case you're going to live for 6 to 7 years more. And we couldn't get it into her head. Educated, ran for Lok Sabha elections, all of that, but we couldn't make her understand that, you are not going to die of radiation, until finally I had to tell her on her face, and then she agreed, and then she started getting PET CTs done. But this is the long and short of it. So I would say, to summarize, in adults, there is no proof or data in 128 years, which is a very long period of time, that radiation produces increased cancer risk from any diagnostic imaging, including cath angios, etc. In children, there may be a possibility, we still don't know. There is no harm being a little more careful in children and not doing unnecessary testing. If the test is required, it has to be done. So, sorry, long answer, but I think it's important to be understood.
Absolutely. Yeah, it is actually eye-opening for all of us because our notion is different. About catheter versus coronary CT angio. When should a family physician order a catheter angio and when should they order a coronary CT angio?
If the patient is symptomatic, you straight away do a cath angio. That's it. You do a coronary angio in patients who have equivocal symptoms, younger people. You're not sure whether the chest pain is truly cardiac. Maybe it's non-cardiac, maybe it's muscle, maybe it's a GERD, but you're not sure. ECG is normal or it's, inverted T waves or some weird thing. Then you get a cardiac CT done, but otherwise you just do a cath angio straight away.
Correct. What is the care that we should take regarding intravenous contrast for coronary or any other CT angio? And what is the care we should take for heart rate reduction or management?
So the landscape has completely changed, right? When we started, the whole thing of serum creatinine, EGFR was a big thing because we believed that contrast agents cause acute kidney injury. In the last 4 years, everything has changed. And today, if you have an EGFR above 30, you can safely give intravenous contrast. So you could have a creat of 2.5 and your EGFR is 40. That's absolutely fine because all the longitudinal studies have now shown that contrast agents, the new ones, the non-ionic intravenous agents, do not carry an increased risk of acute kidney injury. To the extent that if the EGFR is less than 30, and if the study is a must, for example, you need to do a CT pulmonary angiogram for acute PE, then you have to do it. It's the only reason we are a little cautious is because we don't have enough data for those below 30 EGFR. But what we have just tells us that there is no additional risk. So more and more we're not bothered. We still do serum creat in patients simply because now patients are used to doing serum creat. So we're not changing everything overnight. But to give IV contrast today, we are, pretty much anybody can get it and there is no major issue there. The only thing is a little hydration after the contrast is given is all that is required.
Is there any age limit below which we do not advise creatinine? Meaning if the family physician has a 30-year-old and has to do a contrast CT and does not do a creatinine, is there anybody who's going to catch him?
Below 50, we don't do only.
Below 50, no creatinine. Okay. If the GFR is say 30 to 60, which is low but not very low, is there any utility of giving intravenous soda bicarb, oral anything, tablets?
They've done all those studies. Nothing works. The only thing that perhaps may work is good hydration before and after.
So all the use of N-acetylcysteine and other things, molecules, goes out of the window completely. Okay. What about the heart rate reduction or management before coronary CT? It is said that the heart rate should be low, or say around 60, so that the pictures are better.
Yes, that's true. Anything, we aim for 62 to 65, but the machines now are so good that even if eventually we can't reduce the heart rate, we'll still do the study. It's just a lot of work for us to, reconstruct and work with the computer and get good images. But otherwise, it's not that a high heart rate would be a contraindication, but it's just that a lower heart rate gives us better pictures and increases our confidence in the diagnosis.
You're talking about machines. I'll just briefly, if you can tell us, what is your current CT machine and what is the feature? I mean, what is a 256 slicer or whatever? We don't know anything about that.
Yeah, so these are just the number of images that you can obtain at one particular point in time or within a volume. Today we have a 128 slice. The highest is a 320, which Toshiba makes, but Toshiba is now Canon. So that, I think there are a couple of machines in some of the Apollos, not in Mumbai. Then you have a 256, which also is faster, but we don't have a 256 in Mumbai as well. Or most of the machines are 128. Then you have the single energy, dual source. So, where you have two detectors, two sources, again, things are faster. So dual energy and dual source about 10, 20 institutes have. It doesn't make the cardiac CT any better, but in some other areas it just allows you to be faster. So you can do more patients or you can scan sick patients faster in hospitals.
So should the family physician worry about the quality of the machine while sending patients?
Not anymore. Today, even if so for a cardiac CT you need a 64 slice or better. But for any other scan, every machine today is 16 slice or higher, which is good enough for pretty much every scan except a cardiac CT and a CT angio of the limbs. So for that, even carotids you can do well on a 16, even circular Willis. Only the limbs and cardiac you would want a 64 or better. And the funny thing is, there are people who have 16, and sometimes they call it 32, which doesn't matter. And then everybody else has 128 and higher anyway. So you'll anyway know who does cardiac and who doesn't. And that's the only differentiator.
Okay, so just to put again that point across, the heart rate ideally should be 60 before a coronary CT angio is done, and you should therefore either pre-medicate with a beta blocker, and if you use a beta blocker, use a short-acting metoprolol rather than a long-acting metoprolol, meaning use beta lock, not Prolomet XL or Metolar XR, etc. And you can use any dose depending on the BP of the patient, 25 BD or something. Start maybe 2-3 days prior is what I do, but that regimen changes.
So just to interrupt, we've also changed that protocol now. So more and more we tell the patients, don't do anything. Come to the center, we will take care of it. And if it doesn't, we just give IV Ivabradine and sort it out.
Oh, wow, okay.
On table, so that works well.
That's nice. So you should not delay, as he said, the CT study because the heart rate is not achieved. You use IV Ivabradine, not IV metoprolol.
No,
Ivabradine.
So metoprolol we start with, wait for half an hour. If it works, great. If not, then you give Ivabradine.
And do you also give something like alprazolam or clonazepam as an anxiolytic?
Only if the patient is very anxious.
Wonderful. Okay,
so the problem with alprazolam and clonazepam is after that, sometimes they are a little delusional, and then we've had a couple patients go bonkers, because they are not, some people have idiosyncratic reactions to alprazolam, isn't it? If they've never taken it in the past, they start saying things that are completely off, and that in a center can create problems for other patients.
The waiting room can get empty.
So we're not very happy. In MRI we use, because of the way it's structured and claustrophobia, we also have side rooms where we can put the patients away and things like that. But in CT we try not to use all this.
Nice. Okay, I'll go ahead with CT of various areas if you're okay. In a patient who presents with acute abdomen and it's severe abdominal pain, CT is considered very useful. Of course, ultrasound and CT both are very useful. What is your recommendation? Should the family physician go for an ultrasound first, not find anything, then go for a CT scan? Or straight away CT scan if affordability is okay?
Ideally, straight away CT, because except for an ectopic pregnancy, CT will pick up almost everything. So whether it's liver abscess, cholecystitis, appendicitis, pancreatitis, acute obstruction, ureteric colic, everything gets picked up on the CT. My problem with ultrasound, so unless you're 95% sure it's gallbladder, and then you do an ultrasound, it's fine. But if you're not sure what the possible etiology is, then you're wasting time, because a patient gets the ultrasound done, then you get a report. About 3-4 hours go in that. Then if you still have, so if the ultrasound is negative, patient has pain, you still have to do a CT. Ultrasound is positive, unless it's a cholecystitis, you will still get a CT scan done. So why waste time with ultrasound unless it's a way to convince the patient to spend, because sometimes they're not willing to straight away do a CT. That apart, there is no medical reason to waste time doing an ultrasound.
What about acute ureteric colic, which clinically appears to be ureteric colic? Is again a direct CT having some
would
advantages?
say no, direct CT, because you can see the calculus, you can see its size, and people like us who have dual energy, we can even tell you right away whether it's uric acid or non-uric acid
Oh, is it?
calculus.
Yeah.
Yeah. So
So dual energy tells us how that it's uric acid or
because
calcium.
you're using two energies, an 80 kV and 120 kV, which go through the same calculus, and because different materials have different properties of how they absorb the X-ray. So uric acid versus non-uric, the difference is significant. So the machine automatically tells you whether it falls in the uric acid range or not, which is also the reason why dual energy CT is now a very popular technique to diagnose gout, because we can actually see the uric acid crystals in the joints and the tissues for the same reason. So
I have never seen a CT abdomen report where the uric acid or calcium differentiation is mentioned. Is it mentioned by you?
in every patient.
Every patient.
Every
Okay,
patient.
wow.
So again, whoever has dual energy, they will mention it in every patient.
How many dual energy machines are there in the city of Mumbai?
At least 10 to 15 though.
Wow.
Actually.
Okay. CT of the thorax. We did a huge number of HRCT thorax in COVID times. What was your experience in the COVID time?
Okay, so we were not doing those numbers of scans because we are surrounded by so many hospitals that our physicians would generally just send the patients to the hospitals. Also because except for 10 days from the 7th of April to the 24th of April 21, when our staff was not able to come because those ID passes hadn't started, and you know they live in Vasai, Virar, Nalasupara, and they couldn't get transport because taxi guys didn't have those passes. We were shut only for those. But the rest of the times, our biopsy work, our routine CT work, numbers were small, but they didn't stop. And so we actively discouraged COVID patients or suspected COVID. Then when it became difficult to do that, we did them only after 2 o'clock in the afternoon, and then we would sanitize and, you know, or do all of that. So we didn't do large numbers, but we still ended up doing 8-10 a day in the peak, both the waves. Omicron, nobody did CT scans, at least in our part of town. But it was learning. It was a new pattern of disease. We learned a lot from the disease, which even today helps us in our CT chest interpretation. But there were places in India, in Kolhapur, I have a friend who was doing 200 a day. And in the middle of COVID, he bought another CT scanner because he had to do another set. I know Roshan in Pinnacle was among the first to set up an entire COVID facility, and you know, in and out and how, and he actually worked things out beautifully. And I actually would take tips from Roshan as to how to set up the flow of COVID patients and things like the corridor thing. Yeah.
A few terms, HRCT, high resolution CT, what does it actually mean?
It's just an algorithm. We have different filters in our scanners that make the images look soft or sharp, but sharp with good resolution. So high resolution CT started in the earlier days because you actually had to improve the resolution using computer techniques. Today all machines have it standard, and so even whether you say HRCT or not, if it is for interstitial lung disease, the center will give you those images.
So if the family physician is thinking of interstitial lung disease as a possible diagnosis, should he write specifically HRCT?
It's fine. You can say CT for interstitial lung disease, they'll understand as well.
And what is low dose CT?
So that is a specific term that we use in smokers, where LDCT or low dose CT started about 10 or 15 years ago, where people said that screening for lung cancer in smokers will detect nodules and cancers earlier and apparently save lives. To make, basically when the trials went to ethics committees, the ethics committees will say, but you're doing CT scan and you'll give so much radiation. What about additional cancer created by the radiation? Because you're doing a preventive scan. It's not a scan done in a symptomatic patient where you can argue and say radiation is completely harmless. You're taking a normal person and saying, now I'm going to subject you to a test. You at least need to justify all of this. So, and ethics committees also have a lot of lay people within them. So to do that, they brought down the dose by almost 90%. And showed that even with that low dose, you can still pick up lung nodules well. In fact, it became so good that we now use a low dose for everything. And we still call it low dose for smokers because it's become a term. But the same dose is now used for everybody. It's just the technology has become so good that every year a new machine will mean slightly lower dose of radiation to a patient.
How many years do you change your machine, CT scan?
So now it is once in 10 to 12 years.
Oh wow, that's not bad.
Technology has become so good. When we started, it was once every 4 to 5 years. Now it's 10, 12.
What is the cost of a machine? Say your
good
kind of machine.
CT dual energy or high end would be about 5-6 crores. Yeah.
Okay. Okay, so that is about CT thorax related to HRCT, and we talked about low dose CT. So for low dose CT, our usual recommendation is a person probably doing 20 years of smoking 20 cigarettes per year, which is called 20 pack years. Such a person should undergo a low dose CT. Annually, you would say, is the recommendation?
So we have to understand the difference between payments in India and in the US and the UK, right? In the US, all guidelines are based on somebody paying for it. They come out with guidelines because somebody has to, pay, and there is a cost and things like that. So when the USPSTF, that is the United States Preventive Task Force, or somebody comes out with a guideline and says that if you are 20 pack years, which means one packet of 20 cigarettes a day for 20 years or something like that, then your low dose CT will be reimbursed by insurance or by the government for free, right? Or when they say that you should get a screening mammogram done for breast cancer every year, that means in the US, whoever your insurer is, and even if you're not insured, the government will pay for free for that mammogram. Or in the UK, because the UK doesn't have that kind of money, they reimburse once in 2 years. So you can walk into any NHS hospital and get a free mammogram done once in 2 years. If you go every year, then you have to pay out of your pocket, which they are not used to paying out of pocket for any. Those of you who have relatives in the UK and US know that they will wait for a month, but they will not pay out of pocket. And it's not like here where you can get everything done in 1 day from diagnosis to surgery. There, everything takes 1 month, 2 months, 3 months, and things like that. So the 20 years criterion is for reimbursement, 20 pack years. But now you tell me somebody who smokes 1 packet of cigarettes a day for 19 years, that is 19 pack years, is the risk of lung cancer lower than somebody who's smoking 20 cigarettes a day for 20 years? It's not, no? I mean, 19 and a half, 20. But if you're 19 pack years in the US, you don't get a free LDCT because they will not reimburse. It's guidelines, no? Eventually, the cutoffs mean something. So, in our country, where there are no guidelines for anything, pretty much, we even do 10 pack years, 5 pack years, because any smoking has a risk. It's just that the risk benefit ratio to somebody who's paying is more when you only take people who have 20 pack years rather than people who have 10 pack years. But in our setup, anybody who's a smoker who walks in, we will do an LDCT. And we have some pulmonary physicians who ask all smokers to get it done. Simply because, you know, it also, if you find something, then it helps that smoker quit also. So there's a psychology or behind making them do it as well. So.
And the other reason why pulmonary cancer screening has come about is because the treatment has changed remarkably in the recent years. So something that was completely incurable a decade or two ago has become very curable. So it is important that we do. This is a good message that even 10 pack years might be qualifying for LDCT. You don't need more. A couple of more things within lungs. We do often tissue biopsy to detect sarcoidosis versus tuberculosis, etc., or malignancy. How easy it is to do a CT-guided parenchymal biopsy?
So if there is a focal lesion in the lungs, it's very easy to do a CT-guided biopsy. I mean, it's not a big deal at all.
Okay, and do you do it frequently at your center?
Yeah, every day.
Yeah, and the yield is good.
Yes.
The yield the tissue yield is good, so you can get a diagnosis.
Yeah.
Okay. Do you do mediastinal biopsies also?
Yes. So if they are approachable mediastinal lymph nodes or masses, then we do them.
So in a person with, say, mediastinal mass, what is a better investigation? An endoscopic transbronchial biopsy or a CT-guided biopsy? Is there any such thing?
Yes. So if the mass is approachable with CT scan, then there is no question that a CT-guided biopsy is simpler, faster, cheaper and better.
With less morbidity?
Less morbidity, you don't need hospitalization, you can use larger bore guns, you can take a lot more material, all of that. With bronchoscopy or EBUS, the challenge is that it's expensive, you have to hospitalize, the yield is still, they can only use 20 or 22 gauge. So if it's not approachable by CT scan, obviously you have to do an EBUS or one of these more invasive procedures, you don't have a choice. But when you have a choice, then CT or even ultrasound for that matter is always a better modality.
There are many forms of interstitial lung disease, and the form will decide the therapy. For example, hypersensitivity pneumonitis, which is a common form, requires maybe steroids, whereas IPF, that is idiopathic pulmonary fibrosis, requires other therapies like pirfenidone. How useful is transthoracic biopsy for interstitial lung disease, or imaging itself is good enough?
No, so biopsies for interstitial lung diseases have to be either VATS guided or open biopsies.
Okay.
Rarely transbronchial if you're suspecting sarcoid, but for diffuse lung diseases, we don't do CT guided biopsies. There is no role, it is only for focal diseases. But CT itself is very good for differentiating different forms of interstitial lung diseases. And in about 70% of patients, we can generally say whether the patient has IPF or hypersensitivity pneumonitis or sarcoid or connective tissue disease related ILD. We are able to make out. 30% we can't, especially. So Again, in that 30%, if the patient is above 70 or 80, then it doesn't really matter because you can treat symptomatically even if you don't know what it is. But younger patients, 40s, 50s, then you would biopsy because you need to know which one it is so you can prognosticate and decide how to take this ahead.
We'll go to abdomen. First of all, about CT urography and CT KUB. Tell us the difference between these two, urography and KUB plane.
So KUB, when it comes, it's usually a plain scan done only for calculus disease. CT urography is where we give intravenous contrast, and typically you do a plain scan, which is your KUB. Then you do an arterial phase study where all the arteries are highlighted and vascularity of tumors is highlighted. Then you have a venous phase where the veins are highlighted. Then you have a delayed phase after 10 to 15 minutes. So you can see the ureters, you can see the urinary bladder opacified with the contrast, like we used to do with intravenous urograms with X-rays. You injected dye and then kept taking X-rays till 30 minutes sometimes and things like that. So that is CT urography.
So when we are suspecting a calculus only, we order a CT KUB. And what do you do when you are suspecting pyelonephritis? What CT do you order? Is a plain CT useful, or we have to give contrast in pyelonephritis?
So in suspected pyelonephritis, I would first start with ultrasound. That is the good modality. Only if you don't find obvious evidence, or if there is still a discrepancy, or you still not sure what's going on, then you do a CT urogram.
And how will a urogram show pyelonephritis?
It has a pattern. Of,
which will not be obvious on CT KUB.
No.
So contrast will be needed for pyelonephritis.
Contrast. Yeah.
So contrast in kidneys will be needed for infections like pyelonephritis, for tumors. What else?
Assessing function. Sometimes when you're not very sure what the effect of that calculus is, then you would do it. You would also do it for all bladder related, but it's the same thing. Infections and tumors is what you do. Sometimes congenital conditions as well.
What about CT renal angiogram? How useful is it?
Very gold standard. Yeah, it's better than catheter angiography as well, because with catheter angiography, if you understand, you're putting a catheter in, then you're engaging the renal artery. If there is an ostial stenosis, that can be missed with a catheter angiogram. Also, if many patients have more than one renal artery, and sometimes those are missed on a regular aortogram as well. So a CT renal angio, because you give intravenous contrast and then you opacify all the vessels at one time, is the gold standard for assessing number of arteries, status of arteries, extent of narrowing, vascularity of tumors, aneurysms. All of those things are assessed with CT.
So traditionally, when we have a young hypertensive, especially a young resistant hypertensive, we look for renal artery stenosis. And traditionally, we ask for renal arterial Doppler. Now, the point here he's making is, not only is the CT better than renal arterial Doppler for diagnosing renal artery stenosis, but also the ultrasound it can also miss significantly?
No. So I'm going to qualify this.
Okay, sorry.
CT is the gold standard, but I would still start with a renal Doppler.
Okay.
If the Doppler is normal and done with somebody, see the big difference between CT and MR is if the CT renal angio is done well, even if a very junior radiologist has misreported, you can take the CD and send it to somebody else to report, and you don't need to repeat the study. Because the study is well done, anybody in the world can look at the images and give you a second opinion, third opinion. With ultrasound, the operator has to be very good, because there's nothing like looking at the images and then giving a second opinion. Second opinion means repeating the ultrasound study. So if you have a good person, so every time now that I speak, I'm assuming that the operator is absolutely good, etc., etc. Then a negative renal artery Doppler rules out any relevant stenosis. So you may still have a 20% narrowing on a CT, but that's not significant. So a negative renal Doppler is a very, very powerful finding. Then if it is positive, you do a CT renal angio to characterize the extent of narrowing and then take it from there. So renal angio would still be renal Doppler would be the first modality.
In my area where I practice Vile-Parle, etc., I have two good ultrasound operators who can do a great Doppler also. In the city of Mumbai, if we were to quantify the number of good ultrasound operators, how many would you think are there?
In the hundreds.
Hundreds.
Yeah,
So
yeah.
we have many.
Every locality has some very good people.
Correct. So I think our job is not to refer, because I am very uncomfortable referring to a diagnostic center for ultrasound, because there the operators keep changing, you don't know who's operating at that time. So you must find for yourself a good ultrasound guy or girl, who will do a good job rather than send it just ad hoc and tell the patient, aapko jidhar jana hai, jao. That is not probably the correct thing, at least in ultrasound. Okay, how useful is CT abdomen pelvis in a malignancy detection as a screening procedure? If the patient has, or may I qualify that question, if the patient comes with unexplained weight loss, unexplained prolonged pyrexia, how useful is thorax abdomen pelvis vis-a-vis a PET CT scan, for example, if I have to diagnose weight loss and I don't find anything else on my routine blood tests?
So these days we advise a PET CT directly, because it's the same thing. If you do a CT chest, abdomen, pelvis and it's negative, you might still end up doing a PET CT. And a PET CT is anyway a CT from the vertex to the mid-thigh. It's the same quality as a contrast CT of the chest, abdomen, pelvis. The only addition is the FDG, which obviously adds value because abnormal areas will light up with the FDG. So I would, if cost is not an issue, then for severe weight loss, unexplained fever, you straight away do a PET CT. And that's it. So you do a chest X-ray, ultrasound abdomen, examination of thyroid, but beyond that, straight away PET CT.
So we would like to know what is a PET CT. What exactly is done in a PET CT?
So a PET CT is a fusion of a PET, which is positron emission tomography, and a CT scanner. So it's a single machine where half the machine is a CT and half the machine is a PET. The fundamental difference between CT and PET is that in CT, you have an X-ray source which goes through the body, picked up by detectors, and then different areas are shown on a CT depending on their ability to absorb the X-rays or not. In positron emission tomography, which is like any nuclear medicine, we inject a radioactive dye into the body. The patient's body is emitting radiation now, which is then picked up by detectors, and then depending on how much radiation is emitted from which part of the body, you get a picture of that. Now in PET, what happens is, even if you get bright areas, you broadly know where it is. You'll say, this is in the liver area, this is in the lung area, but you don't actually know where it is. So the beauty of PET CT is that the CT gives you all the anatomic information, the PET gives you all the functional information, and the two images are fused together at the same level to tell you exactly where the pathology is, what it looks like, and all of that. So it's a wonderful tool today, for many conditions.
In PET scan, we use FDG. What is FDG?
Fluorodeoxyglucose. It's basically glucose which is tagged with the fluoride radioactive molecule and then injected. So there are no side effects because it's just glucose, and therefore we have to make sure that the blood sugar is less than 200. Otherwise, the FDG is just absorbed in the bloodstream and in the muscles and things like that, and it doesn't work well. So our only stipulation is that your blood sugar has to be less than 200. Very often, if some patients, there are a lot of patients you realize who've never had a blood sugar test done in their lives, and they'll come and we check their blood sugar, it's 300, 400, and you ask them, say, nahi, humne to kabhi checkup nahi kiya hai life mein, things like that. And then you're not sure whether to give short-acting insulin or not. So sometimes we do. If it's 200, 250, then on site we give insulin, bring it down and do it. Sometimes you're not sure what to do. There are comorbidities, etc. Or you talk to the person's physician and they'll say, no, let's investigate why the blood sugar is high, wait for 3-4 days, bring it down, then they come back. So that depends. But FDG in short is fluorodeoxyglucose. It is produced by special machines called cyclotrons, which are very expensive machines and they take up a lot of space. There are 3 cyclotrons in Mumbai. One is in Kharghar. Two in Navi Mumbai and 2 in Tata. So 4 cyclotrons in Mumbai.
So you get your supply and then you
they send it in the morning and there's a whole process to it.
So how many centers who would do PET in Mumbai?
At least 15.
50?
15.
15, okay.
15 to 18, I think.
So that is one form. What is the commonest indication of a PET or a PET CT?
Staging of malignancy.
Malignancy.
Yeah, that's the commonest.
Is there any indication of doing only PET without a CT?
No.
There is no indication. So it has to be always PET CT.
Yeah.
There is another form of CT scan called SPECT. What is SPECT?
So SPECT is it's a nuclear medicine, but the CT is a very, very low-end CT used only to find out where that area of abnormality is. And it's mainly used in cardiology and sometimes for the brain, for Alzheimer's and Parkinson's and stuff like that. So we don't do it. It's done only by the nuclear medicine departments, and in Mumbai de facto it is only done in hospitals because in private nobody actually except one, there are no nuclear medicine centers in private practice.
SPECT is single photon emission CT. So that is, as you said, typically used for some areas where functional knowledge is required. We'll go to another test now. We'll go to cardiac MRI. Cardiac MRI is Bhavin's favorite area of work, or maybe he's one of the very few specialists of cardiac MRI in the country. Tell us a little bit about the indications of cardiac MRI.
So, I guess one way of understanding cardiac MRI is that it is a cross between echo, CT, and nuclear medicine. All 3 kind of combined together to give us cardiac MR. But I think it's it's the best way to understand it is it's like a superior form of echo. What we do in cardiac MRI very well is to evaluate the myocardium. So anytime you have myocardial disease, whether it's an infarct, whether it's hypertrophic cardiomyopathy, whether it is a myocarditis. Cardiac MR is today pretty much the gold standard for all of these conditions. We don't look at the coronary arteries on cardiac MR, so that is CT angio and risk prediction is calcium score. But like you do a stress nuclear medicine, technetium scanning or whatever is done, similarly we do adenosine stress perfusion MRIs as well. So that's why I said we also combine what is done with nuclear medicine and echo and put it all together. So outside of coronary arteries, cardiac MR pretty much looks at everything. Cardiac MR is very good for valvular diseases as well, aortic stenosis, regurgitation. But because echo is so good for the valves, we don't need to use cardiac MR. In fact, the only time we get references for cardiac MR for aortic stenosis is because the patient decided to take multiple opinions, and then one person said it is severe stenosis, high gradient, another echo person said moderate stenosis, moderate gradient, third person said high stenosis, low gradient. Then we do a cardiac MR to try and sort it out. But otherwise, echo is so good for valves that we don't really get into all of that.
So what are the commonest reasons why somebody refers for cardiac MRI to you? What are the commonest indications?
So the commonest indication in my practice is thalassemia patients, where we evaluate iron deposition in the heart because they get blood transfusions and they come every year to see whether chelation treatment has worked or not. The second commonest is viability imaging, where a patient has already had an MI, but was, an angio was not done within 24 to 48 hours, or PCI was not done, or whatever. Then, especially in patients with low ejection fraction, the question is there any viable myocardium available in the area of infarction to justify revascularization? Some cardiologists and surgeons still believe that it doesn't matter what the viability is, you must revascularize everything that is blocked. And they have reasons for that. But many now believe that you must assess for viability, because if it's completely non-viable, why bother? Why open up a complete occlusion of the LAD and things like that? So those patients we scan. Our third biggest indication is hypertrophic cardiomyopathy, and that is only going to keep increasing. So the prevalence of HCM in our country is 1 in 500. Okay, which means at least one of you here has hypertrophic cardiomyopathy, or at least half of us have, half of one person has HCM. Plus it's mostly genetic, so you have then family members and all of that. And as the awareness increases, and as more and more cardiologists now are being produced and have no work in ischemic heart disease, and so now have to start doing other things which have been neglected in India. So, all of this electrophysiology, cardiomyopathies, all of this has been neglected. We are way behind the Western countries. In some things we are very good. In doing stent work and cabbage, we are world class. But when it comes to evaluating hypertrophic cardiomyopathy and then genetic screening and family members and follow-up, we are like 20 years behind all the European countries and the US. That will only change when more cardiologists now start subspecializing in these areas, because there's too much fighting in the ischemic heart disease space. So when that happens, we'll see more and more of these patients being evaluated, because compared to echo, MRI gives a lot more information regarding risk assessment, diagnosis, patterns of disease and all of that. Our fourth biggest indication then is myocarditis in various forms, whether it's genetic, whether it's viral, etc., post-chemotherapy and all of that.
Just one or two indications which are relevant to the generalists. One is viability. So if the patient has triple vessel disease, for example, on an angiography, and if the patient has never had an infarction, it's fairly, there's no need to study viability, ejection fraction of 60%. If the patient's ejection fraction is 45-40%, has an anterior wall infarction in the past, and now you want to decide whether CABG should be done or multivessel angioplasty should be done, they have many options to study viability. Dobutamine, stress echo, or a thallium scan. Is MRI the gold standard here also for viability?
So MR and PET CT are equivalent. Cardiac PET CT. MR is better than thallium scanning. So that's how it
So
is.
between PET CT and MR,
It would
what
always
is less invasive?
MR, no. I mean, in the sense, both are equally invasive. You still have to inject something in the body. But PET CT is very involved. It needs a lot of preparation, fasting, fat-free diet, and then you do the study, and then interpretation is also sometimes a problem. MR is a 30-35 minute procedure, one time and you're done, and no special preparation required. So, yeah.
How many cardiac MRIs do you do in a month or in
No,
a week?
every day about 3-4.
3 for every day. And what is the cost of a cardiac MRI?
The thalassemics are about 8,000, everything else is 20,000.
Okay. Thalassemics are funded by,
Also, most of the thalassemics are funded by some
Charitable
charity or not. So 8,000 is the list price. Nobody actually pays more than 3,000-4,000 rupees. I mean, so thalassemics, I mean, the number of rich thalassemics, that is, thalassemics who are born to rich parents would be maybe 5 or 10 of the total of the 100 and about, we are estimated to have about 1.5 to 2 lakh thalassemic children in the country. And the worst thing is you would hope that by now, there is enough education that has passed down for genetic screening before children are born. Even now, thalassemic majors are being born, and that is so distressing because there is no reason. I mean, in all Western countries, there are no more births. There are only the existing thalassemia patients. We still have births of thal majors here. I mean, that is
Tragic, yeah.
That is tragic. I mean, that whole screening of thal minors in populations that have the thal minor gene or the thal major gene, it's just not good enough. I mean, for whatever reason. So.
Cardiac MRI is an investigation which is expensive, 20,000. But I think as family physicians, we should learn, as generalists, we should learn to kind of think of patients who would benefit with the cardiac MRI. And of course, the cardiologist will be involved in the decision making. But maybe you could suggest to a cardiologist that instead of doing a thallium scan or a dobutamine stress echo, can we do, if the patient is affording, can we do a cardiac MRI? How many cardiac MRIs you said in Mumbai? Did you say that? No.
So theoretically,
Yeah.
about 10-15
Okay.
places can do cardiac MR. There are, I mean, operating at the international level, there are only 2 in Mumbai, mine and one at Jupiter in Thane.
Okay.
And then at a second tier level, you could say there are 2 more, Kokilabin and Reliance HN. That's it.
Okay.
You wouldn't send anywhere else. One of these 4 at the most.
So who's the doctor at Jupiter?
So Nitin Burkule, the cardiologist, runs it along with Priya Chudgar.
Okay.
Priya is the radiologist. In fact, Priya and I have written a book on cardiac MR as well. So.
Oh, wow. Okay. Okay, so that is about this. We are going to take a break at 11. So before that, we'll have a round of questions, and anybody who has a question requested to come up to this mic and ask. Sir, you'll have to come here and ask here so that we can record your question.